This demonstration is intended as a resource for previous students and licensed clinicians who can perform dry needling in their practice acting jurisdiction. Please do not attempt dry needling without proper licensure and training. Regional precautions to consider when you're needling the pectineus include the area of the femoral triangle. The femoral triangle borders include the inguinal ligament as the superior border, the adductor longus is the medial border, and then the sartorius is the lateral border. If you have the patient do an isometric adduction when they're in the hook-lying position, if you palpate from lateral to medial, the first contracting adductor that you feel when they're doing that isometric adduction will be the adductor longus, and that'll be your medial border. And then you can have the patient do if you're in the supine position, you can have them do flexion and external rotation. That'll contract the sartorius. If you palpate from lateral to medial, you'll feel the sartorius contract, and that's your lateral border. And then, of course, the inguinal ligament, which is kind of right at the inguinal crease, that's your superior border. Inside your femoral triangle, you've got your femoral nerve, artery, and vein. You also have some inguinal lymph nodes, and you have the great saphenous vein in there as well. You also have a superficial and a deep external pudendal artery and vein that traverses across the femoral triangle. And then you have a superficial and a deep circumflex iliac artery and a superficial circumflex iliac vein. Those run directly inferior to the inguinal ligament. The pectineus originates from the pectineal line, or the superior ramus of the pubis. It inserts at the posterior surface of the femur on a rough line leading from the lesser trochanter to the linea aspera. It's innervated by your femoral nerve. L2, L3, L4 is that nerve root. Occasionally you can get some obturator nerve innervation as well. The action of the pectineus includes adduction of the thigh, it flexes the thigh, and then it also externally rotates the thigh. If you look at the anatomy to the right of this image, you see the pectineus is highlighted blue. Just to the right side of that, or to the medial side of that highlighted blue image, is your adductor longus. And then, of course, you can see the femoral triangle contents. You've got your femoral nerve, you have your femoral artery, you have your femoral vein, and then you have your superficial external pudendal artery and vein that kind of traverses across the pectineus, and it traverses across the adductor longus as well. And then you see your lateral border of the femoral triangle, which is the sartorius, which is a muscle on the lateral side of that triangle on the left side of this image. You can see the pain referral for the pectineus. The blue shaded area is an area of referred pain caused by a noxious substance that was introduced into that muscle. And then the brown shading represents an area where a greater number of people felt pain when they had that noxious substance introduced into their muscle. It's no big surprise. It hurts at your groin. It's kind of deep groin pain. It can radiate into your pelvic floor. It can radiate for male anatomy individuals, it can radiate towards the scrotum and the testicles, and for female anatomy individuals, it can radiate kind of towards the labia and different areas of the vulva as well. The technique for dry needling of the pectineus includes positioning the patient in the Faber position, which is flexion and abduction and external rotation, with their leg just kind of comfortably resting on a pillow. You don't want the patient to feel like they're having to hold their leg up in the air, so you want to make sure their leg is nice and supported in that Faber position on some nice comfortable pillows. And then you can identify the pectineus no less than 1 finger width medial to the femoral artery. That'll help you avoid the femoral vein. Also, you can identify adductor longus and then treat pectineus just lateral to the adductor longus insertion. That's my preferred method, and that's what you'll see in the video, is you can palpate the adductor longus and go just lateral to the adductor longus, and then you can just slide in next to adductor longus to get the needle into pectineus. Bracket the tissue and needle directly from anterior to posterior with a slight medial inclination to avoid the femoral vein. Roughly a 30 to a 50 millimeter needle length, depending on the size of the patient. Again, as a reminder, you have your femoral triangle, which includes your femoral nerve, artery, and vein, and then your superficial and deep external pudendal artery and vein. You've identified the femoral triangle, you've palpated adductor longus, and then you'll palpate the femoral artery in the femoral triangle. And then you'll, of course, maintain a clean technique. You'll always use gloves, you'll always use an alcohol wipe down. I like to palpate adductor longus and move just lateral to adductor longus, and that'll help me identify the area where I'm going to insert for pectineus. I'll tap my needle in and then slide basically directly behind the adductor longus into the pectineus. Roughly a 30 to a 50 millimeter needle length. Here's another view with a little bit of a close-up.